Good afternoon, everyone. Welcome. I'm Avital Havusha. I'm the Vice President of Programs at the NYHealth Foundation. Thank you so much for joining us today to discuss how the new federal administration could impact New York's public health insurance landscape, as well as efforts underway in New York to enroll New Yorkers and mobilize consumer advocates. Before we get started, I just wanted to cover a few housekeeping items. We'll be recording this webinar, so we'll send a recap within a few days that have all of the materials and links that we share today circulated, as well as the video of the event. Your video and audio as participants are disabled, but we do invite you to use the chat. I'll be monitoring it throughout the event so that I can have questions from the audience towards the second half of the webinar presentation. And we'll do our best to get through as many questions as possible. We also have a closed captioning feature available, and you can find that at the bottom of your screen. So I'll just start by saying we know that we're hosting this event during a moment of real great uncertainty and a rapidly changing landscape. A lot has changed since we sent the invitation. I would say even a lot has changed, as you all know, in the last 24 hours. So our goal today is really to try to strike a balance, to share the latest about federal administrative, legal, and legislative actions that have been floated at the federal level and how those could affect the insurance landscape here in New York. And also to provide some information about what's currently in the works in New York, some of the green shoots and momentum around advocacy to advance previous coverage expansions, and to really mobilize to preserve our gains. So we'll do our best to recognize the real complexity and magnitude of the moment without causing confusion or panic. And we know the stakes are high and things are shifting quickly. So given those unknowns, there are likely questions we won't have the answers to, and especially as related to some of the most recent actions yesterday, but we'll do our best. And we're hoping that you'll leave today with some clarity on the status of where things stand today and how you can get involved. We have such a great group of panelists, and they've been partners of the foundation, and we have a lot to cover. So I'm just going to do some quick intros and then turn it over to them to do some brief presentations. And then we'll have the second half of the event will be some discussion with them. So first, Robin Rudowitz, who's the Vice President and Director of the Program on Medicaid and the Uninsured at KFF at the national level. Elizabeth Benjamin, the Vice President of Health Initiatives at Community Service Society of New York, and Lara Castle, the Coalition Coordinator for Medicaid Matters New York. So I'm going to start by turning it over to Robin, who will kick us off with our slides. I'm going to share my screen, so just give me a moment to get us set up.
Great, thank you so much, and it is great to be here. And as Avital said, I'm Robin Rudowitz. I'm from KFF. For those that don't or are not familiar with us, we are a nonpartisan health policy, research, polling, and news organization. We don't take positions or do advocacy work. We put all of our information out for free on our website, and we do a lot of tracking of state and federal policy issues. So it's a little background on us, and my goal today is to just do a little bit of level setting on the overview of the Medicaid program. I know many of you are, I'm sure, very familiar with Medicaid. A little bit of stats on New York, but leave most of that to the experts, and then talk about some of the key issues that we're watching at the federal level. So next slide. So just as a very zoomed out high level overview of Medicaid, I think a lot of times we forget the multiple roles that Medicaid plays in the overall healthcare system. So it's coverage, nationally it's coverage for 1 in 5 Americans. It's assistance to 12.5 or 13 million Medicare beneficiaries. So Medicaid is the program that helps Medicare work, providing help paying premiums as well as wraparound services for long-term care. And Medicaid, not Medicare, is really the largest payer and provider for long-term services and supports in the country. Medicaid, of course, is a huge source of financing for states and the healthcare safety net, including hospitals as well as clinics. And states also often leverage Medicaid to help address these key challenges related to social determinants of health, maternal health, behavioral health. So Medicaid is a huge piece of helping to address many of those issues. Next slide. Since it was enacted with Medicare in 1965, there have been a few basic tenets of the Medicaid program. One is the entitlement nature of the program. So Medicaid is an entitlement to individuals who are eligible for the program, but also to states who are entitled to matching dollars. This is important foundational concept, since we know that this is one of the key issues that will be under debate at the federal level. And Medicaid, of course, is a partnership. So unlike Medicare, where the federal government sets a lot of the rules, Medicaid is really a partnership between states and the federal government. You know, there's that old adage in Medicaid, if you've seen one Medicaid program, you've seen one Medicaid program, because the federal government sets broad rules and then states really administer their programs. So that's why each state is different. Next slide. We have been trending and looking at state enrollment and spending trends over time. We know that there are different things that drive Medicaid spending and enrollment, particularly during economic downturns. We know that enrollment and spending increase. That happened in the early 2000s, as well as during the Great Depression or Great Recession. The enactment of the Affordable Care Act, of course, increased enrollment and spending in the program. And then most recently during the pandemic, there were a lot of implications for Medicaid spending and enrollment with the continuous enrollment policies that were in place, so individuals could not be disenrolled. So this really increased enrollment in the program. And as the unwinding is playing out, we see more projections for lower enrollment as well as lower spending. Next slide. We also looked at data for 2024. So there were also increased enhanced subsidies in the marketplace. So together, when we think about ACA enrollment, that's really the marketplace as well as the Medicaid expansion. And together, that enrollment accounts for 1 in 6 non-elderly people across the country. 1 in 4 people in New York are covered by ACA-related coverage pathways. And that has resulted in the lowest uninsured rate that we have on record at the national level. Next slide. Across the country, and particularly in New York, Medicaid plays a really important role for certain populations, so particularly low-income children and people with disabilities, so large high rates of coverage for those populations in Medicaid. Next slide. And I don't think I ever do any type of Medicaid presentation without some reminder about enrollees and spending on the program. So this is data for New York that we have, but of course this is true nationally as well, that the large majority of enrollees on the program are children and adults, but the large majority of spending on the program is for individuals with disabilities as well as people who qualify based on age. Again, Medicaid provides that long-term services and supports that really increases costs for those populations. So in thinking about potential changes to Medicaid, it's really important to remember where the spending on the program is. Next slide. For New York, and again, I think others will cover this in more detail, but mirroring trends at the national level, there have been a focus on key waivers. So waivers tend to, and priorities shift across administrations. And New York has a number of new initiatives that have been approved related to health-related social needs, population health and continuous coverage, as well as a number of workforce initiatives. And like some other states that were pursuing coverage for pre-release, New York has a pending waiver for that. Waivers are things that change across administrations, so it is unclear, existing waivers will come up for renewal, and certainly priorities are expected to change in the new administration. Next slide. And then as we look ahead to 2025, and we sort of do an annual piece where we try to zoom out and take a look at what we're expecting in 2025, we know the biggest thing that is going to be facing the Medicaid program is related to what might happen in the federal legislative as part of the budget process, which is expected to be coming out negotiated very on a quick timeline as they're trying to extend tax cuts and looking for programs to help finance the extension of the tax cuts. So the focus really on federal legislation designed to save money is a big focus of what we're watching. I think other key areas to watch are related to work requirements. And again, these are both waivers, but there's also legislative proposals. New administration will certainly have different waiver priorities, but also unclear what other administrative changes, either through regulations or other guidance to states, might occur. We also know that there were a whole set of priorities that states are trying to advance, and there's a little bit of uncertainty about overall state budget constraints and priorities there. And I think an ongoing issue that is something that many states are grappling with is the long-term care workforce. And there have been many efforts to leverage Medicaid to increase provider reimbursement rates and increase services to try to address some of those challenges. So we do have a brief that goes into a little bit more detail. I think that was just put in the chat. But as Avital said, we're going to try to move through slides quickly, and I really look forward to questions. So I will stop there and hand it over.
Thanks, Robin. So Elizabeth, I'm going to turn it to you to dig into, a little bit some more of the detail of what Robin presented on this slide.
Okay, great.
Oh, and just got to get this. There we go.
Okay, so just briefly, let's just talk. I want to level set about what the stakes are for New York State. We have roughly 8.6 million people who have publicly funded health insurance. As Robin mentioned, 7 million enrolled in Medicaid. Of that 7 million, 1.8 million are in the expansion population, where New York gets enhanced Medicaid matching funds. And we're going to come back to that concept, but I just wanted to flag that for folks. Another 1.5 million are in the essential plan, which is the successor to our basic health plan. This is now being funded through what's called a Section 1332 waiver. Waivers are permissions from the federal government to modify federal rules and law for a state. In this case, it's an innovation waiver where we're able to draw down funding that would have been used for advanced premium tax credits to fund our special essential plan. And we'll talk a little bit about that later. And then the last thing is there's another 225,000 people enrolled in qualified health plans, and just a peg on that, of which 153,000 are receiving enhanced tax credits. And we'll come back to that. Next slide. Next slide. We can skip this slide.
Okay.
The thing that's really kind of ridiculous for New York is we get the lowest federal matching rate. We already only get 50-50. That's the lowest level the federal government shares. So the federal government puts up $1, New York puts up $1. In fact, it's the reverse. New York puts up $1 and the federal government will match that dollar. Other states, Mississippi, Alabama, Louisiana, New Mexico, Idaho, they get something between 70 and 80%, maybe higher matching rates. So we already have a very low matching rate relative to the rest, many of our peer states. Next slide. This is the important thing. They need roughly, I don't know, 31, they're basically trying to cut $7.5 trillion in order to pay for tax cuts. One of the things that they would like to do is restore in New York State, the state and local tax cut, which we used to have that benefit that was eliminated in the first round of tax cuts in the Trump administration. They now want to restore that. That would be around $12 billion for New York State taxpayers if we got that restored, if the federal government restored that. But at what cost? And that's what we really have to think about, because the goal for sort of across many of these plans that we've been seeing coming out of Washington is to try to get $7.5 trillion out of the Medicaid program. So that's next slide. Okay, that's fine. We can go on. So these are the basic three options that really seem to be floating to the top, but who knows, we might get something new. the first thing they could do is, remember how New York has that 50-50 matching rate? They were talking about lowering that federal matching rate. So New York would put up, for every 60 cents, the federal government would put up 40 cents. And that could cost New York a lot of money. They're estimating around $10.3 billion on an annual basis. That could really affect the 5 million people in our traditional New York State Medicaid group, but also all people. The other thing they could do is get rid of the federal, right now we have a 90% matching rate for our expansion population, that 1.8 million people that are in that expansion group. That could generate about 4.43 billion, but that again would have an incredible cost to our state, around $4.43 billion a year. Then we talked a little bit about block grants, per capita caps. We can get into that in the discussion if we want to go through the nuances of that, but that would potentially affect all 7 million New York Medicaid beneficiaries. Next slide. So if these draconian cuts to the funding of the Medicaid program happen, how are we going to come up with this money? Well, there's really only 3 ways to do it. You either dramatically raise taxes at the state level, you cut other parts of the state budget, that's education, transport. What else can we do? Or you can institute deep cuts to Medicaid eligibility. Another option would be to drop that $2 million expansion population, or just gut the whole 7 million person Medicaid program. So it's really, these are ugly, ugly choices should this come to pass. Next slide. Just for people's references, I kind of outlined, there's 3 sort of, where are we getting all these threatened cuts from? There's 3 main, actually there's 4 main documents out there. There's Project 2025, there's the Republican Study Committee, there's the House Budget Committee resolution, and there's also the House Ways and Means document that's been floating around. But those are the documents that we've been looking at and where we're drawing this data from. Next slide. Just a quick thing on advanced premium tax credits. 20 million people across the country get advanced premium tax credits. The enhanced advanced premium tax credits are really beneficial for people. They were enacted, during the pandemic and the Inflation Reduction Act, and it will make coverage much more expensive in the marketplace. Next slide. So, there's also a bunch of other options that they could do to cut the Affordable Care Act. And again, these are, they're kind of small beans compared to the trillions you can get out of Medicaid, but still means a lot for the people that have these benefits. They can limit the eligibility on citizenship. So we currently cover DACA, lawful immigrants. We can reform the subsidies. We can repeal DACA coverage, which is deferred action for childhood arrivals. So those are the dreamer young adults and children. They can reform the plan design. They can repeal the family glitch fix. So there's so many options, but they would all be doing this to do for what end? And that's to pay for tax cuts for wealthy Americans. And that's what we have to keep remembering here. Next slide. Let's move on. Next slide. I know we want discussion. You can do the next slide, Avi.
And we're good on time, Elizabeth.
Oh, okay,
so
I'm just worried. So, right now we know about 200,000 people in New York have advanced premium tax credits. That could increase just if they got rid of advanced premium tax credits or radically change them, it could mean the monthly average premium could go up to $714. These are estimates we have. Currently, the average premium is $410. That's a big, big hit for working New Yorkers. Next slide. And then on the enhanced one, we know about 135,000 people have these enhanced ones. If those are cut, it means each person's premium would go up by about $120 a month. And these are people these are working New Yorkers, not wealthy people, or else they wouldn't be in the exchange. And that means they could be paying an extra $1,400 a year. Next slide. So finally, even though they haven't really started talking about it, we do have this amazing 1332 waiver for our beautiful essential plan program, which is great. It's coverage up to 250% of poverty, which, as you can see, is the eligibility there on the bottom right-hand corner. But this coverage is great. No premium, no deductibles, comprehensive benefits. It's such a popular program. As of October 2024, 1.5 million people were enrolled in it. The 1332 waiver generates about $10 billion a year, with $1 billion of which is in an annual surplus fund that we are using to make the rest of our Affordable Care Act products better. Really buying down the deductibles, paying for, really kind of thinking through insurance plan design so that we don't have any cost sharing for pregnant women. We have horrible maternal mortality rates in New York State. One of the barriers to getting good prenatal care is costs. People, we know even $1 in a copay is a deterrent for many people to get care. And so we need to really, and I really commend our brilliant state policymakers and civil service who've really thought through this and really thought through plan design. We want to incentivize people to get diabetes care. We want to incentivize people to get mental health treatment, and we want to incentivize people to get their prenatal care. And that's what we're paying for with some of our surplus. It's really quite extraordinary. Next slide. Or that might have been the end of me. That's so basically, they haven't said anything about 1332 waivers. We would like to think that these are contracts that are secure. Our 1332 waiver really shouldn't be reopened until 2029, when we may have President J.D. Vance or President Democrat, whoever that might be, or maybe President Independent. We don't know. But really, we're hoping our 1332 waiver is in a lockbox. And the reason why I'm slightly confident about that is when we had a 1331 waiver, they tried to change the financing and go backseat on that. And there was a lawsuit, and we eventually New York and Minnesota prevailed on that. So there's a lot more states that have 1332 waivers. And I'm really hopeful that the courts will continue to say these are ironclad contracts. They shouldn't be reopened on political whim. And that's it for me. Thank you very much.
Thanks, Elizabeth. So I'm going to turn it over to Lara, who's going to share a little bit about what's happening at the state level, and also some of the great things that have been continuing here at the state. And then we'll jump into questions. There's already some good questions in the chat about some of the specifics around how some of this could play out, and we definitely plan to get into that. So I'm going to turn it to Lara, and then we'll go from there.
All right. Good afternoon. I see my job today as reminding all of us about why Medicaid matters to New Yorkers. Medicaid Matters New York is the statewide coalition, and our job is to bring this message. This is what we do. We highlight the reason why Medicaid matters, the reasons. And I borrowed this image from KFF's state fact sheet on Medicaid. We use that fact sheet all the time in our advocacy. It's very well done. It uses graphics to depict what the components of Medicaid are and who is impacted, what the services are, et cetera. So you can find that on the KFF website. You may also find that it's a tool that is useful to you. This image is meant to remind us who is covered by Medicaid in New York. And as you can see, you all can read those numbers and see the graphic there. Medicaid matters to a variety of different people in New York, and this is meant to show who we're talking about. And when you think about who these people are, you also think about what the services are that these people have access to that they wouldn't have access to if they did not have insurance coverage. So again, we see this moment as reminding, particularly important in this moment, is doing the job of reminding all of us why Medicaid matters. And that is because it is insurance coverage for all of these categories of people, all of these people who are touched by Medicaid in some way because they have insurance. They are not uninsured. We still do have people in New York who are uninsured, and we can talk about that. But New York has recognized over the years that we can use public insurance coverage to make sure that people in New York have access to healthcare and services that they need to keep them healthy and well. Next slide. So in New York, we have a very rich history. As I just said, New York has recognized we can use public coverage to make sure that people are not uninsured so that we can have people accessing the services and the coverage that they need. We need to build on New York's very rich history in this regard, especially in this moment of uncertainty. And we can do that by leveraging some of our recent wins. And I'm just mentioning 3 here because I think they are particularly poignant examples of some of the accomplishments that we have gained over the last few years. And even though we may not be able to see some of the next steps come to fruition, now is the time to keep up the momentum and leverage these wins to get further on in our advocacy role and in our what we want to see next in our program. So implemented this month, January 1st, we have continuous eligibility in Medicaid and Child Health Plus from birth to age 6. That is a big win. We are celebrating that as an expansion of the ability for the youngest New Yorkers to stay enrolled in public coverage. That means they will not have to do the paperwork all the way until they reach kindergarten. No paperwork barriers to stay enrolled in health insurance in New York for young kids. And what do we want to do next? How would we leverage this moment? How would we leverage this opportunity? We think that there should be continuous eligibility for everyone. New York is one of the states that provides 12 months continuous eligibility in Medicaid. Not all states do that. And we believe that there is an opportunity to explore potentially 2 years of continuous eligibility, which Oregon did a few years ago, maybe 3 years of continuous eligibility. Let's continue that conversation so we don't lose the opportunity to recognize the value of doing away with paperwork barriers for people in the program. A couple of years ago, we leveled the eligibility playing field for older adults and people with disabilities by having their income eligibility match other adults. And we believe that the eligibility equity should continue across populations. So we would propose to repeal the asset test. People with disabilities and older adults, people over 65, continue to have an asset test in order to be eligible for Medicaid. This discussion is ongoing. It's something that the governor proposed a few years ago in the budget that fell out of the budget negotiation process. There are ways to do it incrementally. There are different strategies around how to do this. We believe it's time to repeal the asset test, again, building on this idea that everyone in the program should have equitable income eligibility for the program. Also, a couple of years ago, another fantastic win that is still being implemented now, coverage in Medicaid for people 65 and older, regardless of immigration status. We have had a coverage for all campaign that Medicaid Matters has supported and echoed over the last many years. We think that this step towards coverage for all is another important opportunity to keep that conversation going, keep those dialogues open and flowing so that we don't lose the chance to gain more access for coverage for people in New York State, people who reside in New York State, regardless of status. What else is on the horizon? I would say probably the biggest thing that continues to be an issue for many people, many of our coalition members, as well as constituents and partners across the consumer advocacy community, which is also something that Robin mentioned is on the KFF watch list, is access to home and personal care. We need to examine ways to enhance and support the workforce that people rely on in order to have home care and personal care to live independently in their homes. There are many aspects to this topic regarding wages, regarding career opportunities, how to make sure we have the workforce that we need. It also comes down to some pretty intricate, detail-oriented rules around managed care and managed long-term care. And we want to make sure that ultimately there are no barriers to people having access to home and personal care, so that, you know, people can stay in their homes living independently through addressing the workforce issues and other issues. I think we'll get into this during our discussion, but I think it's important to say that we are in a unique, although we have been here before, sadly, we are in a unique time of uncertainty. With that said, it doesn't mean that we are going to back away from New York's history of providing a Medicaid program that people can rely on for their health and well-being. There are many ways that we will continue to do this, even if we aren't able to achieve some new wins in the next few months and years. And we can continue to talk about that in our discussion. Thanks very much.
Thank you. I'm going to just stop sharing. Give us all great. Thank you all so much. That was so helpful. And there's so many good questions in the chat. So we're going to do our best to get to some of them. I'd like to actually, there are a few kind of level set questions on some of the kind of basics of Medicaid enrollment and how Medicaid works. So I just want to cover those, and then we'll talk a little bit more about some of the federal actions and what's happening at the state level. So first, there were a few questions related to the federal matching rate, the FMAP. I thought maybe one of the basic questions was, why is New York's only 50% when other places are higher? I thought maybe, Robin, could you tell us a little bit more about FMAP? And then Elizabeth, maybe you can touch on some of there was a follow-up question about the matching rate related to the essential plan.
Sure. So the match rate is actually set by there's a formula in the statute that's based on states' relative per capita income. So the way those calculations have worked out, there are about 10 states, including New York, that, and then there's a floor of the 50%. So based on those calculations, year after year, New York has been at the floor in the match rate of the 50%, but they update those match rates for the traditional program in the Federal Register each year based on this, based on the formula.
Great, thanks. Elizabeth, you want to jump in on essential plan?
Sure. So the essential match plan doesn't have like a technical match rate per se. It's really, we basically get 100% of what we would have gotten for the same population if they had APTCs and they enrolled in qualified health plans. But the real bottom line is if you looked at it as a match rate, we have $1 billion surplus. So that's a pretty good match rate. That's like whatever, 110% match rate. So we're doing great on that financing formula. And it's all due to the fact that our individual market insurance coverage is so expensive. And so that's what it's pegged to. And that's, what so that's how it works. And we're great beneficiaries of that. And it's been one of my life's work to make sure that we've been able to draw down those federal dollars, first for basic health plan and now this 1332 waiver. So we can actually offer really good coverage for people.
Great. And then just one other level set question in terms of coverage. There was a question about Medicaid coverage of people with serious mental illness, and KFF is actually working on some analysis on that. So stay tuned and keep a lookout on KFF's website for some of that information. And then there was another question about coverage for people over 65, regardless of immigration status, that newer population. Can either Lara or Elizabeth comment on, where that stands now?
So Lara, you want me to do that?
That's fine. Yes.
So this is really important. It's also important. It's also kind of related to the question about the trans coverage of trans care for people, for youth. So New York pays for, in Medicaid program, we pay for all medically necessary care. So for example, someone asked something about endometriosis, that is covered. The trans care has been covered through lawsuits and litigation. So so our benefits will stay the same, especially because they're subject to lawsuits. On the over 65 people who are immigrants, undocumented immigrants over 65, they will retain their coverage unless there's a change in state law. That population is 100% state only funded. So the federal government typically cannot go in and take back a benefit that has been levied by a state legislature. A good example of that, all these years, we have been paying for all medically necessary abortions. The federal government will only pay for, they had this Hyde Amendment, they will only pay for, many of you might remember if you have gray hair like me, they only paid for like the threat of life of the mother and, blah, 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 blah. So we paid, basically our Medicaid program kind of wrapped around that conditional coverage. So we draw down all the federal matching funds we can, and then we buffeted it with state-only funding. For the over 65 population or undocumented immigrants, we will continue to cover them.
Great. Laura, anything to add, or did that?
I would just, Elizabeth has it right, of course, and I would just add that, we as an advocate community have been tracking the 65 and older implementation to make sure that it goes as smoothly as possible for the people who are entitled to that. That's one of our jobs as consumer advocates, is to stay in touch with state policymakers and state officials who are implementing these important programs to make sure that our job doesn't end when something is enacted. Our job continues, and they are continuing to, work out the technical kinks and make sure that people are aware of the program. And that is something that we continue to do.
And I also want to say, for our children age 0 to 19, we fund our CHIP program with 100% state funds to make sure undocumented immigrant children get that coverage as well, which is well-deserved and needed.
Great. Thank you. So I want to shift now back to some of the bigger picture questions around what's on the horizon in terms of federal action. There's a few questions in the chat that I'll try to kind of combine. I think one of the first things that Robin set up for us was that one of the most proximate actions that we might be able to expect is Congress's budget resolution process. And there were kind of those 4 items floating around: per capita caps, the FMAP rate, the expansion match rate, lowering the FMAP floor, work requirements, that there's some talk that maybe those could get addressed during some kind of deficit reduction process. So I was hoping that maybe someone could speak to what's the timeline or unknown timeline on that front in terms of when that could happen.
Wait, I want to just correct you. It is not a deficit reduction.
Oh, sorry.
It is to pay for tax cuts for higher income people. And that is, we cannot, I'm sorry. I cannot let that go, because that is not what's going on here. I mean, so
thank you.
Sorry.
Good. No, good. No, it's helpful. Thank you. So thank you for the correction. So in general, though, the budget resolution process, tell me a little bit more about what we don't maybe know about the timing on that front and when it could play out. And then there's kind of this complementary overarching question that I think everyone has about what are things that that would take executive action versus a congressional action, assuming things stay as is. What type of changes require congressional action versus can be done with executive action, even though I think there's also some uncertainty there. So let's start with the budget resolution process. I don't know if, Robin, you want to speak to some of what you know about the timeline, and maybe Lara and Elizabeth can jump in.
Sure, I'm happy to share. I mean, we don't have any inside information, but we are sitting in Washington, so a little bit closer to things as they're playing out. But they're trying to move a budget resolution very quickly and have goals of having a budget resolution in place by the end of February. And what the budget resolution does is that's a document that's passed by both the House and the Senate. And it would really set these targets for various committees to meet during what's the next part of the process, which is the reconciliation process. And then all the committees with jurisdiction would need to hit these targets. So that would mean in the Senate Finance on Medicaid, and in the House, Energy and Commerce. And if there is this big number put in the budget resolution of, in these proposals that have been floated around, and Elizabeth walked through all of those, the details of the implications, that $2.3 trillion dollar number, then the committees would need to come up with the detailed legislative policies through the reconciliation process to meet that. And there was some hope that that would happen by April. I mean, these are very aggressive timelines. so it's unclear if there'll be agreement on a budget resolution and certainly agreement on major policy changes by April, but those were some of the goals that had been set out in terms of timing for the process.
Any Elizabeth or Lara, do you have any other insights into the unknowns?
No, I think Robin, pretty much, I'll defer to the Washington-based people to explain to us what's going on down there. Thank you for your service.
And I think some of the follow-up question on that in terms of congressional or executive action, actually someone who just put into the chat, and Elizabeth, you touched on this a little bit around what could be the actions around the advanced premium tax credits, anything related to the ACA. So maybe you can just touch on that a bit.
Yeah, I mean, there's a lot of ways to kind of eviscerate the ACA. The first thing they can do is just let the enhanced advanced premium tax credits, that extra financial assistance lapse. They can get rid of, they can basically allow states to dumb down what essential coverage is. And so then people would be buying essentially junk insurance through the marketplace with very, very high deductibles and lower benefits. They could further cut the actual amounts of the APTCs that are the standard amount, and they could just dumb down the insurance design and sort of have like the benchmark plan be a bronze plan, which only pays for whatever 40 cents, 60 cents on every dollar of premium. It's just, let me count the ways of how they could really destabilize health insurance for Americans and residents of New York State. It's quite upsetting. I don't know, Robin, you want to toss in any more, or Lara? I mean,
well, go ahead, Rob.
Oh, no. I was going to jump back on the administrative side on Medicaid, but I don't know if you want to.
I was too, but you go first.
I mean, just I'll do the high level and then you can get into the details from New York. But certainly there are a lot of things without legislative action that a new administration could do around shaping Medicaid. And those are really around waivers and rules, so federal guidance as well as sub-regulatory guidance. So these are the letters that go out to state Medicaid agencies about, how to run their program. And there's a lot that can be done to really change and shape programs. I see there were some questions about the impact of the New York waiver. And, I think the answer is that we don't really know. The waiver, there have been provisions that have been approved. They're approved for a 5-year period, but there are provisions that new administrations can look at waivers. That was somewhat unprecedented, but certainly that did happen in the last administration with the rescinding and withdrawal of waivers related to work and premiums. So, I think we'll be watching very closely to know the new direction of where waivers are going to go in the future, and certainly what happens with pending waivers, and then what happens with waivers that have been approved. And then there have been a number of really significant rules that were made final that have a lot of implications for Medicaid, both related to managed care and access, as well as nursing home staffing. Those are, there's been talk in the legislative process as trying to repeal those through legislation. But also, again, if that doesn't happen through the legislative process, there could be new rules that would be repealing or overturning some of the rules that were in place related to access, managed care, and nursing staffing.
That was an awesome overview. And I will just add, from a New York perspective, we have heard some New York officials say to us, and also publicly, that they see our waivers as contracts. And, the hope is that the nature of these waivers being signed contracts between the federal government and the state, that there is a binding agreement that would be legally challenged should, something be rescinded or changed in any significant way.
Yeah, I think the problem for New York is, unfortunately, our 1115 waiver ends in the next couple of years, maybe it's less than 2 years. And I think there's a real vulnerability for that, the idea of getting that one renewed. We'll see. But it seems to me that any waiver that's called a health equity waiver, given what's going on in the last week, has a bit of a target on its back right now. And sorry to use violent language, but I'm worried for it.
Yeah, absolutely. And I mean maybe let's segue then actually into some of the state pieces. So there's been a few questions here about, kind of the protective measures the state might be able to take. And of course, the governor did release the executive budget just recently. So I wanted to just maybe touch on a bit from Lara and Elizabeth. Is there anything that you saw, like, or you see any opportunities through that process where, given the enormity of what's happening, the state could be putting some protective measures in place?
You want to go first, Laura?
Sure. So, we are still analyzing the budget.
Yeah.
It's a big document,
Yeah.
documents. What we have seen in our initial analysis is that Medicaid is staying essentially flat. And we also recognize that there may be some opportunities to discuss through the budget process for New York's Medicaid program. The overall state budget outlook has been reported as much better than anticipated. So that means that there could be opportunities, as well as the funding that New York has brought in with the use of a Medicaid, a managed care organization, an MCO tax. And we would like to be part of the discussion about how we can use this time when we do have a little bit of extra money to use in Medicaid to, for instance, make investments in primary and preventive care, make investments in long-term services and supports, going back to what we said before about ensuring access to home care and personal care. And that might mean an investment in home care wages this year. We hope that there will be opportunities in this year's budget to, build on the strengths of the program and recognize where the needs are, and, maybe change things up a little bit and make investments where we haven't in the last few years.
And on that list, I would just really like we know that right now in the Medicaid and commercial managed care networks that there is not enough mental health capacity along with primary care capacity. And we really need to have adequate networks serving people with mental health and substance use needs, as well as just basic primary care. And I would really hope that with this MCO tax, that the state really invests in building networks and surveilling networks and making sure that we don't have, as the Attorney General described, ghost networks for major areas of care like mental health and substance use. The other thing that, just pivoting back to sort of what we can do to sort of, can I say Trump proof, or like a federal proof the state's healthcare ecosystem, at least in the commercial and in the qualified health plan market. I think two things that we did in 2017, 2018, I believe, we did do an ACA conforming law. So a lot of our insurance protections have been codified in state laws, that we pulled many of the protections from the Affordable Care Act and inserted them into the insurance law. There's a couple of areas that I am concerned about. In that process, we referred to the U.S. Preventive Services Task Force, and a lot of that Preventive Services Task Force is why we have free colonoscopies, for example. And if the Trump administration decides that task force should no longer be, which I think someone actually suggested, or if they no longer want to follow the guidance of that task force, I think New York State would need to clarify the colonoscopy should be free, and a bunch of other preventive services need to be free. And then there's another area, which is in protecting people against discriminatory conduct. It was called the 1557 regulation. It's pretty clear that will be rescinded, repealed, modified. I'm not sure what they're going to do, but I feel like we could potentially strengthen some of our anti-discrimination provisions in state insurance law and public health law. Of course, we annoyingly regulate our health insurance across two agencies. So some of it's in the public health law and some of it's in the insurance law. I'm constantly being asked to comment on people's, great bills around various things. And I'm like, well, it's nice that you're only regulating insurance, but you might want to do the HMOs and the public health law too. So, we have to always be mindful that because we incoherently regulate insurance across two agencies, it would be great to maybe use the MCO tax to maybe have a coherent regulatory infrastructure where, like, California does, for example, where they have one agency, kind of enforcing, surveilling, implementing health insurance rules.
Great.
I'd like to just
jump in.
I just would like to add one other thing, and I think Elizabeth and I could probably talk about the state budget
Yeah.
all day. But one thing that I would add is that now more than ever, people are going to be calling on our consumer assistance programs. And we have incredible consumer assistance programs in New York that do a really good job of, making sure people can just pick up the phone or make an appointment or whatever they need. And people are going to have a lot of questions in this time about their coverage and what do I still have access to this? There was also a question or a comment in the chat about what's happening in the immigrant community right now. And people are, there are a lot of frightened people right now, and the consumer assistance programs now more than ever need to have the state's backing to make sure that they continue to operate.
Thanks.
So full disclosure, CSS is kind of the administrative hub for a bunch of those consumer assistance programs. And if any of your patients need assistance, and in some cases providers need assistance with confusing questions and stuff like that, the phone number is 888-614-5400. Please send them to us. We have multilingual staff who can, talk immigrant folks, immigrant patients through these issues. It's complex, and people, really are going to need some pretty in-depth counseling about what's to come.
Thanks. And you read my mind. That was the question I was going to ask, is what is it for both of you who've been doing this work now with navigators, with the consumer assistance community? Have you started to see, changes in people's behavior in terms of coming to ask for help? And are there other resources out there that or others are sharing, even for those people who might be working directly with patients, to clarify any misinformation, disinformation, et cetera?
Yeah, I mean, we're doing that a lot every day. The beauty of our consumer assistance programs, in my mind, is we have two ways to reach people. You can do a live answer, that 800 number I just gave you, but we also have partners with an extraordinary group of community-based organizations on the ground, like Make the Road New York, like South Asian Council for Social Services, like the Adirondack Health Institute. Like you name a corner of New York State, and we have an amazing community-based organization partner that can help people in person, because a lot of times we do have our consumers coming in with a plastic bag full of all their papers from the last year, and someone needs to sit down and sort through those papers and make sure, that people are on track to getting care. And that's what we all care about, is making sure we have a healthy state where people can access care. The other thing I would just like to note is, unfortunately, the Navigator program was just baseline at the $28 million this year in the governor's budget. And if there's ever a time where we want more navigators, and these are our enrollers out on the street, helping people enroll and resolving these questions, it might be a good idea for the legislature and the governor to come together and give that program a bit of a boost from that spending. That's basically the same funding we've had since 2013.
Robin, were you going to jump in? Thanks, Elizabeth.
Oh, I was just going to follow up on one key point about coverage for immigrants.
Yeah.
And we do, and another colleague of mine at KFF is going to be doing some other estimates, but we know from the first administration and many policies that were targeting immigrants that did affect coverage and utilization among not just people who are undocumented, but people who have legal status and who continue to be eligible, many people in mixed status families. So the implications of some of the policy go well beyond in terms of practice and what's happening with coverage and utilization, well beyond the the actual policy and have broader effects. And we'll be doing some more of those estimates that should be coming out soon.
Great, thank you. So, we only have a few minutes left. There's many questions. There's some specific questions in the chat that we'll make sure to follow up on around specific services related to long-term care, and home and community-based services. So we don't have time to cover those today, but I did want to pivot a bit to a question about litigation in the courts, and then a little bit about what people, some of the partnerships that are being built up and what people can do to support the state at this moment. So starting with the court question, but it's a little bit going back to the top around what we might expect in terms of action. And so, Elizabeth, I was hoping maybe you could just speak for a minute about what we think the role of the courts might be, especially given what we saw yesterday, and what people might be able to expect there.
Yeah, I mean, I'd like to say there's two things. Number one, the most important thing people can do is engage in public education with policymakers who might be based in Washington, to impress upon them how important Medicaid and the Affordable Care Act is for our state. We will suffer if there are cuts, like on the order of $10 billion. That is a huge portion of our state budget. And patients will suffer, providers will suffer. Unions will suffer. We must all come together and organize and do local town halls and local community meetings to get the word out. That's what we had to do. The last time they tried to go after Medicaid, and, we bless John McCain in heaven or wherever he is, for his thumbs down gesture and basically saving Medicaid as we know it. And we will have to do that again. And we have lots of members, who we really need to engage with, and, and just make sure they have all the facts. On the courts, I think, we can try to rely upon the courts, but this is a political moment. And so we need to really impress, to do good public engagement with our members. Last night, I can't tell you how many calls and emails I got yesterday saying, was our programs closed down? The portal's closed, blah, blah, blah. We are really lucky. We have a great attorney general who whipped into action along with 22 other state attorney generals and said, no, you don't just get to stop the Medicaid program overnight, even the OMB realized they couldn't stop the Medicaid program overnight, and they had to quickly backpedal. I think part of the game plan here is to create chaos. And so there'll be a lot of courts, having to, a lot of judges wasting a lot of time, batting down these kind of half-baked, efforts to cause panic and confusion. Or I don't know if they're intentionally doing that, but that's certainly the impact of them. And so, we have the courts there, but we also have a big problem, which was the Chevron case has been reversed. And I learned that at Columbia Law School. And so, really the Congress is going to have to be very explicit about what it wants to see happen. And, the courts will have to defer to the words of Congress instead of the agencies. And that's going to be a real new era for all of us.
Yeah, definitely topic for even another webinar. Lara, is there anything that you wanted to share in terms of kind of calls, what others can do at the state level, adding to what Elizabeth maybe just shared?
Absolutely. I think Elizabeth's point about education right now cannot be underscored enough. Now is the moment to remind people, as I said before, remind people about what Medicaid is, who it serves, what those services are that those people rely on. That will be what we need to do to make sure that our members of Congress are reminded of the importance of this, and reminded that, proposals that come across their desks may be seen as state flexibility, or they may be characterized in a way that has them think, oh, this wouldn't be so bad. And we need to remind them that the proposals that come across their desk are cuts to make sure that there is enough money in the budget for other things. And the other things in this case are not the things that we believe in. They are, we need to see that our public programs remain strong, and reminding our policymakers at every level what the potential threats are and how they would impact on New Yorkers is really what we need to do now. I would direct people to our federal issues website, which is where we continue to put resources and information so people can stay informed and involved.
Great. And Robin, we're just at the close. Is there any last things that you wanted to share in terms of either KFF resources or other thoughts?
No, I would just say definitely check out our kff.org. We're constantly updating with new information from our policy side, polling information. And we also, on our state health facts, have a lot of state-by-state information as well. And I encourage anyone to reach out if you can't find something on our website, which is sadly often the case. We probably have the number, so let us know if you need help.
Great, thank you. And so we're just at time. This was so helpful I'm sure for everyone involved. We have so many more things we could talk about. There's several questions in the chat that we didn't get into, especially around like other coverage, including CHIP. So we'll be following up. Please feel free to reach out to us at the foundation, and I can help make connections. We'll make sure to share all of this in a follow-up email to include a whole range of resources of how you can get in touch with various folks. And we really appreciate everyone's energy that they brought today. So much wealth of information, and looking forward to continuing this conversation so that we can really support New York's Medicaid program and all of the amazing work that you have all done to date. So thanks so much. I hope everyone has a nice afternoon. We'll see you at our next event. Thanks a lot.